Hi, everybody. Cool. Thanks for joining us today. So we've got a bunch of people online, and we've got a bunch of people here in person to join us for our PT Matters presentation today, our student-focused session. So I just want to start by acknowledging the land that we are on. So Dalhousie University operates in the unceded territories of the Mi'kmaq, Wolastoqey, and Pescataqownie peoples. These sovereign nations hold inherent rights as the original peoples of these lands, and we each carry collective obligations under the Peace and Friendship Treaties. Section 35 of the Constitution Act 1982 recognizes and affirms Aboriginal and treaty rights in Canada. And we also recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched that part of Mi'kmaq known as Nova Scotia for over 400 years. And I don't know if it's raining outside now, but it's been super rainy the last little while, so hopefully that will continue. The flowers growing and the trees getting all the leaves. It's been beautiful having spring here. So we have 3 presentations today from our students. So we have a PhD in health student, MSc Rehab Research, and combined MSc in Physiotherapy student presenting, and then we have a group of students from our 6202 Scientific Inquiry 2 course who received the highest grade in the course. They're going to be presenting today as well. So we're going to start with Sarah, our PhD in health student. So Sarah Remedios is, did I say that right? Yeah. Okay. Is a PhD candidate in health at Dalhousie University, where her research in clinical biomechanics focuses on shoulder kinematics and neuromuscular adaptations. She currently serves as a project coordinator and data analyst for the Dalhousie Arthroscopy and Sports Medicine program, leading research initiatives in orthopedic surgical outcomes and virtual medical education. With a strong academic foundation from the University of Waterloo and a background as a research associate, she has contributed to over a dozen peer-reviewed publications and international presentations. So I'll pass it off to you.
All right, thank you for having me to present some of my research today. So I'm going to be talking about how the shoulder moves, the biomechanics before rotator cuff surgery. So I'm going to combine some of my biomechanics background as well as my clinical research experience within this talk for some of my PhD research. So for this talk, a couple of my objectives are to identify key biomechanical deficits that impact shoulder kinematics in massive rotator cuff pathology, as well as explore characteristics between different maybe phenotypes, which I'll talk about in a bit, within a homogeneous sample of a rotator cuff population. We know that with adults older than 70 years of age, about 50% of the population have some form of rotator cuff tear. This does not mean that they all have the same functional limitations, and this does not mean that they all have pain. But for those who do have pain and functional limitations, they often seek surgical consultation or they go to their doctor to see if they can improve their quality of life, their conditions, and kind of perform their everyday tasks. So this is what a rotator cuff tear looks like inside the shoulder. So at the top of that figure, you see the rotator cuff tendon. That would be like the supraspinatus and infraspinatus on the shoulder. And then the bottom, you see the humeral head. That hole where the arrow is shouldn't be there. So that is what a large or massive rotator cuff tear looks like within the shoulder. So as you can imagine, for a lot of people, it provides significant limitations. So we want to learn and know more about the shoulder, but shoulder and rotator cuff tears in particular are very challenging. So why they're challenging? Well, the shoulder complex is very complex. There's a balance of mobility and stability as depicted in the measuring scale on the left-hand side of the figure there, where as you move your arm, it's also imperative that it stays within your shoulder joint so that you don't dislocate or which can cause some pain. So the muscles of the rotator cuff, as well as the deltoid, are depicted in the middle figure, and so those are the muscle lines of actions. And so when you move your shoulder, the rotator cuff moves the shoulder, and it also helps to keep it within the joint. So if you can imagine with that large tear and that gaping hole, that shoulder might have trouble staying within the joint as you're able to move your arm or go up. So how do we measure shoulder function? And we kind of want to know in both biomechanics settings and clinical settings. So we often look at the overall motion of the shoulder, or thoracohumeral or humorothoracic, whichever you want to call it, which is the relative motion of the humerus in respect to the thorax. And this is one's ability to lift their arm basically above their head. It's measured in different planes, such as flexion, abduction, and scapular plane abduction, which is in the front of the plane. For this presentation, we'll really focus on flexion. But these are important to measure because while you might not be walking around doing your tasks with the straight arm in the front or to the side of you, you do go through those motions as you're performing a task. So let's say you're screwing in a light bulb, you're flexing your arm likely to bring it up to the ceiling in order to screw in a light bulb. So we kind of, in the clinic, we take a step back. We don't get people in the clinic go, hey, can you show me how you screw in a light bulb or like turn a key? No, we get them to flex or abduct or do things like that. So that's what we want to measure and look at differences. But when you have a rotator cuff tear, what happens? We see a lot of variability in the literature. And so this is a good study that shows the variability. I know it's a little bit older now. It's almost 10 years old, this study. But the figure on the left, I know it's a little bit small, but it shows various sizes of rotator cuff tears. So with the light blue being subacromial impingement syndrome and the dark blue being a massive rotator cuff tear, we see not only there's a decreased range of motion in flexion, abduction, external rotation, as some examples highlighted, but there's also a large variability. So for flexion and abduction, this study kind of showed the ranges of people with massive rotator cuff tears to be between 30 and 170 degrees. So this shows that rotator cuff biomechanics or shoulder biomechanics are variable with the rotator cuff. So can we look at this further? Can we maybe dichotomize or break down people who can lift their shoulder versus people who can't lift their shoulder? And to kind of compare this to something that we might know a little bit better about is the ACL literature talks about copers versus non-copers, people who can cope without an ACL and people who can't and maybe seek that surgical consultation. So we want to kind of shift some of the thinking from the knee and in this area to the shoulder and what that looks like if there are differences. So that leads me into the research objectives. So the first one is to determine if there's even a subset of individuals we can classify, right? Taking that variability, can we classify, and I'm changing some of the terminology to not confuse with the knee literature, for adapters and those who are limiters, which I'll explain. And then once we determine that, or if we can determine that, are there differences in the biomechanics, the neuromuscular kind of effect that there is within the shoulder, individual strength, their range of motion, as well as subjective patient outcomes, so how they are feeling. And then lastly, we wanted to compare this to an asymptomatic age-matched population. So we recruited those asymptomatic individuals into the Joint Action Research Lab. They had to be over the age of 50 years old because we know that the older someone gets, the more likely that they'll tear their rotator cuff. And when I say older, I do not mean old. And there's no past or present history of shoulder pathology, as well as no known musculoskeletal injury that would impede their ability to participate. We then recruited our rotator cuff population, our rotator cuff group. This is from the orthopedic clinic at the Halifax Infirmary. And people had to have a positive diagnosis of a two tendons, so the supraspinatus and infraspinatus, and a tear size of about greater than 3 centimeters. And so we identified that by the retraction of the cuff off of the head of the humerus. So their MRI kind of had to, I guess you're not seeing my mouse. I was pointing. That's okay. This one.
Yeah. And then if you just do laser pointer.
Oh, okay. That one. So this is where the tendon is supposed to be attached, and it has retracted all the way over to right under the acromion. So that's where the acromion is. And so, again, that's kind of that gaping hole that we saw at the beginning, and so that's what they had to be identified as to be in the study. They also could not have really much muscle atrophy. So when we looked at their muscle atrophy within their shoulder, their supraspinatus and infraspinatus, they couldn't have more than 50%. So they had majority of their muscle still there. So once they were in the lab, this is in both populations, we instrumented them with reflective markers to capture optical motion tracking of their torso and their arm, as well as we put electrodes on a variety of their muscles to get their EMG. They went through a shoulder assessment protocol while being instrumented, and we did do 9 different tasks in loaded and unloaded conditions, but I wanted to focus on the flexion for this study in particular. So we looked at maximal flexion and the outcomes of that, as well as flexion to the height of the shoulder. So we put a target at each person's shoulder height, and we loaded it with a 2.5% body mass load. So it was relative to everybody's weight. We then did shoulder strength measurements that are often done in a clinical setting or a physio setting. And again, we'll focus on flexion because it's relevant to those lifting tasks. And then the patient-reported outcomes we used were Western Ontario Rotator Cuff Index and the American Shoulder and Elbow Surgeons, or the ASES score. Those two measure the someone's self-perceived shoulder function and their pain and their ability to do their daily lives because of their shoulder injury. And then we did a quality of life questionnaire as well, just to determine their overall health and how they perceived that. So the first thing we wanted to know was the adapters. Are they adapters or are they limiters? So we identified this using their thoracohumeral motion, where adapters were greater than 1 standard deviation from the asymptomatic group, and limiters were defined as less than 1 standard deviation. We got 148 degrees, or about 150 degrees in our asymptomatic population of full forward flexion, which meant that adapters were classified as anyone greater than 136 and limiters anyone less than that. So I'm just going to start by pointing out that we recruited 20 people to the asymptomatic group, and then we had 51 people come from that orthopedic clinic and diagnosed with similar tear size and similar muscle atrophy. And 30 of those people were identified as an adapter, whereas 21 people were identified as a limiter. When we look at their demographics, the only significant differences were that the limiters were significantly older at about 5 or 6 years. And in the adapters and limiters groups, there was over 80% of the population were males, whereas the asymptomatic group had an equal distribution of males and females. So into some of our kinematics, the full flexion, unsurprisingly, we designed the study this way. The asymptomatic and adapters group had similar full flexion range of motion, but the limiters only had about 112 degrees of forward flexion, meaning they couldn't get higher than that on average, and they also had a larger variability. When we get into the loaded flexion condition, so again, lifting that load in front of them with the 2.5% body mass, both the adapters and the limiters had significantly less shoulder flexion than the asymptomatic group. So that asymptomatic group got up to their target, I would say all of the time just from remembering, but the adapters and limiters, like everyone in the cuff group, didn't. The other significant differences in this were that the cuff group did lift significantly more load. However, when you look at it, it's only about 0.2 to 0.35 kilograms. So I don't necessarily know if that's the limiting factor in this. So then we ask why, I guess. Why are the limiters limited in the situation where the adapters are, right? So one of the things from literature and what we kind of look at is motor control, where we had greater than 50% of the adapters to match that asymptomatic group for that full flexion. Perhaps they had an inability to recruit their motor units appropriately due to that disrupted force couple, right? So that supraspinatus and infraspinatus are torn. There's a big hole in there. Maybe they're unable to produce or recruit their motor units appropriately. Perhaps it has nothing to do with strength, which I'll talk a bit later again. So this figure is just showing the difference in the waveforms between the limiters in gray, asymptomatic group in black, and adapters in the dotted gray. The other solution, or the other reason, that this could be is due to mechanical factors or maybe impingement within the shoulder. So we also tested their passive range of motion, and if there was maybe no limitations in impingement or pain in the limiters group, we might see similar passive range of motion, so when you're moving their arm, as the asymptomatic and adapters, but we didn't. We still saw significantly less passive range of motion in that limiters group. This could suggest that there's increased impingement within the shoulder, within that subacromial space. So again, that rotator cuff tear, as they lift their arm, they come closer to the acromion, and there's maybe some limitation or pain as that rotator cuff tears, essentially. So we also found that when we had the subjective outcomes, that the limiters group had a perceived quality of life that was less than the adapters, but their overall shoulder rating, their perceived shoulder ratings, were similar across groups. Okay, so why did the adapters have the same functional range of motion, but they were similar to limiters when you added the load? Well, I really think that it's just kind of like a strength deficit. So when we looked at their shoulder flexion strength, both groups did have significantly less shoulder flexion strength than the asymptomatic group. This could be due to a loss of an effective leverage within that shoulder, right? You're tearing your rotator cuff. That moment arm within the shoulder joint essentially becomes zero, and your inability to lift that load is impacted. So it might not be the case, the strength might not be the case for that full range of motion, but once you add the load, it really demonstrates the differences between an asymptomatic population and a population with a rotator cuff tear. So looking into some of these muscle patterns a little bit further, we looked at them throughout. So this is kind of a wild spaghetti plot, but essentially we put all of their EMG waveforms into a single matrix, and we used a pattern recognition tool called principal component analysis, or PCA. Essentially, this reduces the dimensionality of the data set and provides us with patterns or trends. So when we look at some of those patterns and trends, we see that we found 3 principal patterns that showed the most variance within the data set. So there's some that show overall kind of shoulder elevated muscle activation, some show elevated muscle activation in the lift portion, and some showed elevated muscle activation in the lowering portion. I provided one example because there was a lot of muscles, but in the anterior deltoids, we actually saw adapters, which are in the red here, show a little bit more of a similar kind of, like, they look different, but their values were different. It was really hard to depict this, so just imagine. But when we looked at our anterior deltoids, our adapters actually showed a little bit more of a similar curve than the limiters did when looking at the asymptomatic group. However, both cuff groups showed kind of significantly more an elevated peak muscle activity throughout the entire movement. So, do these classifications, or are they relevant postoperatively? We had about 60% of the population identified as an adapter before surgery. What about after? I don't have that data yet. We're collecting that, so that's next. I just kind of wanted to preemptively talk about it. So essentially, we were able to kind of take a structurally homogeneous group or sample of adults with rotator cuff tears for shoulder flexion tasks and find some differences between them. So we did find some people with a full flexion range of motion, and we found some people without. However, the limiters and adapters were significantly limited by their strength when they were unable to lift the load. Thank you.
All right, so we've got a couple minutes for questions, either online or here in person. I have a question to get us started. Did you expect to see that percentage of adapters versus limiters, or did you have any expectation?
That's a good question. I didn't have any expectation. I think clinically, as we're going through each collection, it felt like it was going to be a 50-50 split between the two groups. So I think maybe expected kind of a similar distribution. Yeah.
Is that similar to what's seen in the knee?
I don't know.
I don't know either.
Yeah.
I'm wondering, is there any association between the size of the tear and likelihood of being more of a limiter versus an adapter?
Yeah. So I would
Can you
just.
repeat the question?
Oh yeah. So the question was: is the size of the tear any indicator on people being a limiter or an adapter? So I think that it would. Our population was only people with really large rotator cuff tears. I believe in the clinical setting that I also kind of work in and have some experience in, they don't get seen until the tears are that large, so we wouldn't have as big of a population. But some of the variability research where it shows that effect of rotator cuff tear on their range of motion does show it declines as the tear gets bigger. So I think you would still get, I think the distribution would change, going back to the first question. I think the distribution would change and shift as the tear gets smaller into more adapters.
Next we have Kaela Trumble. So originally from Cambridge, Ontario, Kaela is a Dalhousie Bachelor of Science Kinesiology alumna from 2022 and is in the final year of her combined MSc Rehab Research and Physiotherapy program with a special interest in frailty and cardiovascular disease. Throughout her degree, she has enjoyed presenting twice at Crossroads, the interdisciplinary conference, and competing in Dal's 3-minute thesis competition, receiving 3rd place for her presentation. Kaela is looking forward to combining her research interests and clinical skills gained during her master's studies into practice, working as a physiotherapist in Nova Scotia when she graduates. So I will get your notes back up here. That bigger. And then it's just there if you want. Okay, take it away.
Well, thank you everyone for being here. I'm going to be discussing my topic of frailty trajectories in people with and without cardiovascular disease. So what I'm hoping to go over today is to discuss what frailty is, look at how frailty and CVD interact, and then discuss my results and how these may apply to you. So first I want to talk about the paper boat theory by Dr. Patricia Cantley as described in the British Geriatric Society Journal. So technically, frailty can be defined as affecting many physiological systems which causes a person to experience a decrease in their physiologic reserve and resistance to stressors. But what does this mean? Well, here we have Millie, Joan, and Norma, who are all 85 years young. Millie is like a steamboat. If she's going through the middle of the Atlantic and a hurricane hits, she's going to dip and bob, but she'll get through to the other side just fine. Then we have Joan, who's like a rowboat. She wouldn't make it through a hurricane in the Atlantic, but if she's in the middle of the Halifax harbor and the winds pick up, as they always seem to, again, dips and bobs, but she'll get through just fine. Then we have Norma, our paper boat. If she's in Sullivan's Pond on a beautiful sunny day, she can get along for a little while, but you never know when the weather's going to change. And the minute the winds pick up, it's too much for the paper boat. And this is what we mean by physiologic reserve. The higher the frailty score, like Norma, the harder it is to handle stressors on your body. So, as mentioned, frailty causes a person to experience a decrease in their physiologic reserve, and this disproportionately affects older adults, and has been shown to increase the chance of adverse health outcomes. Frailty rates are on the rise globally, and this is concerning as it decreases quality of life, increases loneliness, can lead to cognitive decline, and worsen mobility. Having the ability to measure frailty provides researchers and healthcare professionals the insights into personal and population health. But how do we measure frailty? Well, it can be measured in many ways, with the most popular methods being the frailty phenotype, the clinical frailty scale, and the frailty index. Focusing on the frailty index here, it's an accumulation of deficits model and a continuous scale between 0 to 1. It's calculated as a ratio with the number of deficits present divided by the number that was measured. Using the frailty index, the global prevalence of frailty is around 24%. It covers a wide range of areas of health information, as shown here, and shows us how vulnerable an individual may be and is validated in predicting adverse health outcomes. So frailty and CVD often occur together, with one study finding that about 25 to 62% of people living with CVD were also frail. Frailty is also a predictor for disability, and in a study by Frailty and colleagues, it increased the probability of death by 3 times when compared to the robust group. So CVD and frailty have a clear connection. However, it's also important to assess how frailty can affect CVD development. In one study, they found that there's an increased risk of CVD of 70% for those considered frail compared to those who were not frail. This emphasizes the importance of frailty screening in health settings to allow health professionals to understand who may be at an increased risk for CVD events and early mortality. So, one challenge with current research is that many studies only consider a measure of CVD or frailty at single time points to predict health outcomes. Investigating changes in frailty, called trajectory, helps knowledge users to understand how frailty typically unfolds over time and provides an understanding as to why some people accumulate at a faster rate than others. To exemplify this, we have an image from Stoltz and colleagues in 2001, where you have person A, or Millie, and person B, or Norma, who had similarly few health deficits at baseline. If we only looked at their frailty scores at this time, we would assume they would progress at a similar rate. As seen, they have similar survival predictions at time 1. However, if we look at Norma, she had a faster accumulation of deficits, as seen in this line here, whereas Millie had almost no progression. This illustrates how assessing frailty through repeated measures improves the ability to anticipate further health deterioration than at single time points. So this brings me to my knowledge gap. So evidence shows a connection between frailty and CVD, but no research has examined frailty trajectories in people with and without CVD. And as just mentioned, using repeated measures is more advantageous than single time points. The hope of this study is to lead to the implementation of algorithms to alert healthcare professionals to those at highest risk. So this brings me to my objectives and hypotheses, which were twofold. First, I wanted to determine if frailty trajectories are associated with developing CVD, and then to compare these trajectories in people with and without. I hypothesized from this that these trajectories in people who rapidly accumulate health problems will be more likely to develop CVD, and be greater in people with versus without CVD. This study was a secondary analysis using data from the Canadian Longitudinal Study on Aging, which follows over 50,000 people between the ages of 45 to 85 years at baseline, who will be followed every 3 years for up to 20 years or until death. I used the questionnaire data to form the Frailty Index. The CVD variables look at mortality and sociodemographic variables, and I used baseline, follow-up 1 and 2, or around a 6-year time span. The CVD variables that I used were myocardial infarction, heart failure, stroke, transient ischemic attack, and peripheral vascular disease. These were collected through a self-report questionnaire with a doctor asking, has a doctor ever told you have, and the variable in question being filled in. So, for the analysis of this, for objective 1, I wanted to determine if frailty trajectories are associated with developing CVD. We used growth mixture modeling to investigate latent groups or unobservable groups of participants who share similar frailty changes. We used a procedure as described in Ram and Grimm 2009. Once we reached an appropriate growth mixture model, we used Cox proportional hazards regression analysis to look at the association between these trajectory groups and the development of CVD. For objective 2, we then wanted to compare the trajectories in people with and without. We started by testing for an interaction effect between frailty and CVD, and then when found significant, completed trajectories in people with and without, using the same procedure as described in the first objective. So, for the first group, looking at those developing CVD, we had around 40,000 people at baseline. Anyone who had CVD at baseline was removed as you can't develop it if you already have it. And as you can see here, the mean frailty scores increased from each time point. The baseline had about a 0.064, which is equivalent to 2.6 deficits out of 41, and increased to 0.078, or about 3.1 deficits out of 41. The maximum frailty scores also increased over each time point, reaching a highest point of 0.56, which is equivalent to about 23 deficits out of 41. Again, frailty also increased over each time point as a percentage of the population, and interestingly, it actually almost doubled from baseline to year 3. If you look at the histograms here and focus on the base of it, you can see that with each time point, it's getting wider, which means that more people are moving into that higher frailty category. The model that we selected was a 3-group quadratic model. We had our low stable group, or our milli group, which represented about 32% of the population. We had our low increasing group, or our Joan group, which represented about 54% of the population. And then we had our high accumulating group, or our Norma group, which represented about 32% of the population. Now, 13.7% of the population. Now, while Norma only had 13% of the population, she had 100% of the individuals that were considered frail at any time point. And of the 5,600 people in her group, a third of them were considered frail. So what does this mean for the risk of developing CVD? Well, if we use milli as our reference group, Norma had a 234% higher risk of developing CVD than Millie did. Now, Joan had no one in her group who was considered frail. However, she still had an 86% higher risk of developing CVD due to those higher frailty scores. We also considered age and sex, and for each additional year of age, your risk increased by 4%, and if you were male, you had a 43% higher risk of developing CVD. Now, how do these trajectories differ in people with and without CVD? Well, after running our chi-square, we found that there was a significant interaction between Frailty and CVD, so we modeled those with and without. Those without CVD represented about 70% of the population, and those with was about 30%. The mean frailty scores in those without CVD was around a 0.068, or about 2.8 deficits, whereas those with CVD, it was almost doubled at a 0.1 or 4.3 deficits out of 41. As well, in the no CVD group, only 3.3% of their population had someone was considered frail at some point, whereas in the with CVD group, 15.6% of their population had someone that was considered frail. And do note that while they only had 30% of the population, the number of people who were considered frail at some point was almost double that of the no CVD group. Once again, looking at the histograms, those without CVD had quite a left skew, showing those lower frailty scores for the majority of people, whereas those with CVD, it was a much higher distribution into those higher frailty levels. So for both of these, we got 3-group quadratic models. And if you look, they have the same y-axis, but each of the kind of like same group for each one, that those with CVD had higher trajectories at each level. To clarify this even further, the dotted lines are those without CVD, and the solid lines are those with CVD. And again, each group is higher than those without CVD. As well, if we look at frailty, similar to our first group we looked at, only the Norma group had anyone who was considered frail, and it was about 1/4 of their population. However, in those with CVD, even into that kind of middle group, that low increasing group, 2.7% of the population was considered frail at some time point. Now, while that might seem low, they also contained almost 60% of the population for those with CVD. So that's still quite a few people. And in that high accumulating group, 81% of the individuals in that group was considered frail at some time point. So what does this mean? Well, it means that those with CVD are more likely to have higher frailty scores outside of their CVD burden, and they're more likely to be considered frail, which increases their risk for adverse health outcomes. So why should physiotherapists care about this? Well, we already do intake paperwork in many environments. The frailty index can be as few as 30 questions, with many of them being yes or no, or things we already look into. And the frailty phenotype is 3 questions of weight loss, physical inactivity, and fatigue, and 2 measures of gait speed and grip strength, which we might be measuring already. As well, we should also ensure we're screening for CVD and understanding the importance of that for our clients in our rehab plans. As well, think back to that paper boat theory. If we have a deeper understanding of the effects of frailty on our clients, we can adjust our rehabilitation plans to fit the needs of our clients. Because, as we know, it depends. And frailty levels is something that can impact recovery. As well, great news, frailty is not inevitable and it is reversible. Exercise has been widely shown to improve frailty scores, even in those who are the most frail. This is like adding a wax seal to the bottom of your paper boat. And finally, physios place a large emphasis on physical health and activity, which is one of the best prevention strategies for frailty. This can be especially prevalent in cardiac rehab. In a great systematic review by McEachran and colleagues, they found that those who had the highest frailty scores entering cardiac rehab also had the greatest improvements in their frailty by the end. So understanding where someone is in their aging journey and how to help them age well, we can hopefully help them to reduce their frailty risk. I want to thank the Canadian Longitudinal Study on Aging for allowing me to use their data for my research, my supervisor, Dr. Scott Kaela, for all his support throughout this process, my committee members, Dr. Caitlin MacArthur and Dr. Olga Theo, and all of you for listening to this presentation and hopefully taking a little something on frailty with you into your clinical practice.
All right, any questions in the room or online? Go ahead, Derek. Oh, Ellen. Okay, Ellen.
Yeah, thanks for the presentation. For like one of your slides, you showed kind of how you calculate frailty, like all the different components of it. I noticed one of them was chronic conditions. Mm-hmm. Is one of those chronic conditions cardiovascular disease?
No, that in the original frailty index we used, it did have all the CVDs I listed, but we removed those before calculating to look at frailty like outside of that CVD burden.
Okay.
Okay, so it didn't affect the scores.
Okay, because I was kind of thinking, I was like, yeah, like if you hadn't done that, then it's kind of like, yeah, CVD's used to calculate frailty. Yeah, but that's, okay.
Go ahead, Derek.
Great, thanks, Kaela. On one of your slides, when you were comparing no CVD and CVD, there was a line in the box that had max. Mm-hmm. Is that the max frailty index?
That was the maximum.
Because it was like 0.57 and 0.57 or something like that. Yeah,
yes.
Or 0.56. So I'm curious, is that right? Is that the max frailty index for each group?
Yes.
Yeah. So what would, I'm curious why the maxes weren't much different.
Yeah, so actually that's something I noticed as well. I think it's just that, even without cardiovascular disease, people can still have quite high frailty scores, which I think kind of exemplifies that there. But showing that more people were kind of in that lower level just means that they're less likely to, as well, because the Frailty Index covers a really wide range of health deficits. Also, we do see in frailty research that the more deficits that you have, like, kind of snowballs into accumulating even more. So yeah, it's kind of interesting to see that, but I think that's more of an outlier than the typical. Yeah.
Any other questions? All right, thank you so much, Kaela. We'll transition over. All right, so I know it's a little crowded here now. Oh. Okay, perfect. Okay, so our next presenters are our group from Scientific Inquiry 2, PHYT 6202, who had the highest grade in the course, and they were one of my groups, so that's very exciting. I wasn't involved in marking or anything. That's how it worked out. It worked out very well. So they're going to be talking today about how transitional care has been operationalized, delivered, and evaluated in Canada. So we have Lily Jacobs, Hannah Elliott, Heather Manning, Thomas Chaulk, and Ellie MacAulay. So take it away. Maybe whoever's speaking, if you want to stand in front so they can see you online, and then you can just step into the spot.
Where do we click at? Are you guys going to click? Or is
I
it
think
just
it
here?
should work. Yeah, go ahead. You might just need to put the cursor back over to the screen. Okay, now try.
Yeah.
Do you need to share the screen?
No, it's good.
All right.
Okay.
Good. Good?
Yep.
All right. Good afternoon, everyone. Thank you for joining us either in person or online and taking time out of your day to listen to some great presentations. My name's Ellie, and I'm joined here with my classmates, Lily, Thomas, Anna, and Heather, and we're here to talk to you a little bit about our research surrounding transitional care. All right, so first we'd like to give you guys just a little bit of an overview and do a quick little introduction of what transitional care is, our objective for our research, followed by our methodology, results, limitations, and future directions, and then finishing off with a conclusion and our references. So to start, I would like to define transitional care. Transitional care aims to ensure continuity and coordination of care for patients transitioning from hospital to home. In Canada, there's variability in service delivery, which may impact outcomes for older adults with complex needs, and this has kind of led to our discovery of a knowledge gap, showing a limited understanding for how transitional care is being operationalized, evaluated, and delivered in Canada. And that leads to our scoping review that we did for our research, showing how transitional care is being operationalized, delivered, evaluated for older adults transitioning from hospital to home.
So for our methods, we conducted a Joanna Briggs Institute methodology, and then we reported our process using the PRISMA SCR guidelines, which is on your left-hand side there. We searched CINAHL PubMed as well as Academic Search Premier for English published studies from 1990 and onwards. 1990 was chosen as based on our initial search of the literature. There was no relevant articles prior to 1990. We also then developed our search strategy based on that initial search of the literature, and then we adapted it based on the databases that we were using. We also hand-searched all the reference lists as well to identify anything that would be relevant to our scoping review going forward. Our eligibility criteria for this review included adults age 55 plus, and sorry, we did use the PCC framework for this as well. So adults age 55 plus who were living in Canada and transitioning from either hospital to home or hospital to long-term care, and included how those programs were defined, delivered, and evaluated. We included quantitative research studies and excluded qualitative studies, reviews, as well as grey literature. Our study selection was completed on Covidence, where we had 2 independent reviewers screen the titles and the abstracts, the full text review, as well as the extractions. And then if a disagreement was kind of arose, it was resolved through either discussion or a third reviewer. Risk of bias was assessed using the JBI critical appraisal tool, and we classified studies as either low, unclear, or high. But of note for this study, it's important to say that we did use all studies regardless of the quality. So then finally our data was extracted using a standardized form that was created for this review, and we organized to identify common program characteristics, participant details, and information describing the transitional care program.
So circulating back to our Prisma SCR chart, we originally identified 1,735 studies. Based on our inclusion criteria, only 9 studies were identified and included in this scoping review. It's important to note that 49 studies were assessed for eligibility in the full text review, but 25 were excluded because of wrong study design, which will come up again in our limitations section.
So, for our results, we included 9 Canadian studies published between 1999 and 2024 that looked at transitional care programs for older adults moving from hospital to home. As shown in the table, there was a wide variation among studies in terms of models of care, program duration, and healthcare teams involved. Despite these differences, most programs aim to support a safe transition home and reduce hospital readmissions or functional decline. So continuing to look more broadly at the results, the studies included a mix of RCTs, quasi-experimental studies, and program evaluations. These older adult participants transitioning from hospital to home often had complex needs or an increased risk of readmission. In terms of how transitional care was set up, there was some variation between the programs, but they were mostly community-based. These included rehab-focused programs, nurse-led interventions, case management models, and virtual wards. When looking at the delivery, there was also some variation. Some programs were short-term, just a few weeks long. One was even a single discharge planning session, while others were a few months or even longer. Most used a mix of home visits, phone call follow-ups, and community programs or services, along with a multidisciplinary team that also varied depending on the program itself. So key takeaway here is that transitional care models did vary widely across Canada in nearly almost every measurable dimension.
So then looking at our outcomes, we created a pie chart, as you can see on the slide here, to compare non-RCTs and RCTs. As you can see, there were some commonly reported outcomes across all 9 studies: emergency room visits, hospital admissions, functional status, and patient experience. Fewer studies looked at quality of life as well as mental health, suggesting that these outcomes remain underexplored within the current literature. Across studies, there was no statistically significant difference between intervention and usual care groups in key outcomes such as hospital admissions, emergency department visits, mortality, length of stay, and functional outcome. However, we did have one study from Custer and colleagues who reported a decrease in emergency department visits based on the transitional care program that they used. Despite the lack of significant clinical improvement, several studies reported positive findings in patient-reported outcomes. These included patient satisfaction, access to information, self-management, knowledge of available services, and ability to manage their overall health.
There are a few important limitations to consider in our study. So first of all, there's differences in the terminology used to describe transitional care. For our study, we use the term transitional care program, as this is the predominant term used in Canada. However, other terms such as post-acute care, alternative care, restorative care may also be used. However, programs using these terms were excluded from our review. We also only included quantitative peer-reviewed literature. This means that programs described in qualitative and gray literature were excluded. However, throughout our search, we found that many programs are currently described in qualitative and gray literature. In fact, 25 studies were excluded at full text review due to wrong study design. So as a result, it is likely that additional programs exist, but were just not included in our review. Our search also only identified 2 provinces with programs that fit our inclusion criteria. This made it difficult to compare programs across provinces, but also highlights this important gap in the literature. So future research should focus on strengthening the limited peer-reviewed evidence of transitional care in Canada. Expanding research to other provinces and territories will give a more complete picture of how transitional care is being implemented across the country. This will help to evaluate how effective and feasible these programs are, which is important for health system planning to develop programs that best suit patient needs and reduce outcomes like hospital readmissions and emergency department visits, especially within our aging population. So although our research focused on transitional care programs more broadly and did not specifically examine physiotherapy's role in transitional care, we felt it was important to highlight the relevance of physiotherapy practice here today. As future physiotherapists, we believe we play an important role in transitional care by supporting mobility, functional independence, and safe community reintegration across healthcare settings. We believe transitional care programs should be included as part of the interdisciplinary team to help optimize recovery, reduce functional decline, and promote independence after discharge. Additionally, understanding current transitional care models can help physiotherapists advocate for improved access to rehabilitation services and expansion of care programs across Canada, specifically in Atlantic Canada.
So overall, this scoping review explored how transitional care is operationalized, delivered, and evaluated across Canada for older adults transitioning from hospital to home. What we found as a group was that transitional care programs are delivered using a variety of interdisciplinary and community-based approaches, including nurse-led programs, rehab programs, and case management models. Despite differences in delivery, most programs focused on improving continuity of care, supporting patient independence, and reducing gaps in the care following discharge. In terms of outcomes, evidence suggests that these programs may improve patient satisfaction, healthcare navigation, and access to information and self-management. However, there was very limited evidence showing significant improvements in major clinical outcomes such as hospital readmissions and emergency department visits. Another important finding was the lack of Canadian research overall, especially in Atlantic Canada, rural communities, and the territories. This highlights a major gap in the literature and suggests that more rigorous and standardized research is needed. To tie it all together, transitional care programs appear promising for improving the patient experience during the transition from hospital to home, but other research is needed to better understand how these programs can consistently improve clinical outcomes in supporting Canada's aging population. In closing, we would like to thank Dr. Caitlin MacArthur and Dr. Rebecca Moyer for all of their guidance, feedback, and for this wonderful opportunity to strengthen our research skills and knowledge on transitional care programs in Canada. References? Thank you. Any questions?
Any questions? Okay, Kaela.
So you mentioned there was only 2 provinces. I was wondering which ones they were and like what differences you think you might see across Canada if it was broader.
So it was Quebec and Ontario. We have chatted a little bit about what differences we think we could have seen. Of course, like we mentioned, a lot of the studies that are currently done on the Atlantic provinces were in grey literature, but we do expect that it will be pretty similar in terms of we might not see major differences in emergency room visits, but patient satisfaction, just knowing that they have that support, as well as navigation. A lot of the studies talked about having a better understanding of community services available to them. So the only difference could be in rural communities that those services just aren't available. So in terms of access, we could see differences there, but overall we think it will be pretty similar.
Other questions?
Thank you very much for the presentation, folks, and congratulations to the class. I was going to ask Ellie what it's like working with a bunch of new planners. However,
I'm from Cape Breton, so it's not much.
Yeah.
Like I'm the closest you can get.
So it does speak, I think, somewhat to Kaela. So I noticed in your chart or your tables that it was Ontario and Quebec, and not only just Ontario and Quebec, because there's a lot of rural Ontario, but it didn't even hit rural Ontario. It was really the urban centers of Toronto, Hamilton, and Waterloo. So what would be different about a rural center? So when you looked at these literature, you may be from rural settings, so what is different about being in rural from what you learned in this that we may be able to apply?
Yeah, so we didn't obviously, like you said, it was urban centers that all of 9 studies were from. So it was including a lot of things like community programs, facilities that they could use. Some, I believe, were visits back in the hospital. Some were virtual visits. So we're all from rural. So community access, not many places have walking programs rurally. Not many places have even the ability to have virtual appointments. Even thinking rurally, the people who have access to Wi-Fi is even limited. The ones who know how to use the Wi-Fi, the ones who are transitioning from hospital or to long-term care or to home, are often the ones who don't have the Wi-Fi to do a virtual visit, don't have the access to go to a walking program to continue to rehab. So, like, no, we didn't necessarily look at it, but I think we did talk about it as a group that I think it would be different, unfortunately, in a rural community, but I think we all think it would be helpful nonetheless.
Any other questions? Online or in person? All right, thank you very much.